inviting me to talk with all of you this morning. Thank you, Dr. Samit Bajral. I was initially thinking this is going to be a very small, informal affair, but it has grown into something quite impressive. And I'm hoping that for people who are on this call this morning, this will be useful. Thank you, Dr. Sindora, for the very kind introduction and again, hosting me this morning. As you've already mentioned, I am a professor of pathology in the section of hematopathology at the University of Chicago and Pritzker School of Medicine. I also oversee the clinical laboratory where we do our hematology testing and flow cytometry. I do have some disclosures. However, there is no conflict with the content that I'm going to discuss today. I get royalties from UpToDate for contributing to some of the chapters that they have online, and I have received some honoraria for consulting work done for AbbVie as well as Jazz Pharmaceutical, but none of that poses any conflict with the information that will be discussed today. So the goal today is to just walk everybody through, and it's possible that some of this is repetitive and content that you're already familiar with, but my mandate when I first got the call from Dr. Gujral was to just make sure I go through some basic morphology of the cells in the bone marrow, and what I have done is just that. So we will look at what are some of the normal cells present in the bone marrow. And at the end, I have 5 or 6 cases that we will use as examples to understand some of the abnormal findings that we encounter on a fairly regular basis. So why study the bone marrow? Why do we even need to be familiar with this, more the content for this morning's discussion? You're all familiar with these kind of results that we see all the time. It's a type of complete blood count as well as differential that's listed there. And I refer to these as formed elements. And in a healthy adult, these are maintained within relatively narrow range. And the way these are maintained in this narrow range is by this sort of constant back and forth that happens. So we're obviously looking at the peripheral blood here. There's some homeostasis by redistribution into the tissue and lymph nodes, particularly for lymphoid cells and monocytes and macrophages, as well as spleen. There's some consumption, so there's loss due to aging or senescence, as well as cell death when these cells have reached the end of their lifespan. It can be as long as 120 days for red cells, or a couple of hours or a few days for platelets and neutrophils. And so that's the loss that happens from the peripheral blood. And then there is the site of hematopoiesis in the bone marrow, where you have this undifferentiated hematopoietic stem cell that matures into the formed elements that are present in the peripheral blood by the process of hematopoiesis. And if we want to see what is going on or what is causing a problem with the formed elements in the peripheral blood, the bone marrow examination is the way to do it. And then the process of hematopoiesis, again, in the steady state, is controlled by cell-intrinsic responses that are mediated by these transcription factors like PU.1, GATA1, CBP alpha, and CBP beta, or RUNX1. These are the cell-intrinsic factors. They respond to exogenous cytokines when there is a need. So, for example, if there is tissue hypoxia, there will be secretion of erythropoietin, which will then function through this transcription factor GATA1 and result in generation of these erythroid precursors. So, again, there are cues within the body that the bone marrow responds to by the effect of these cytokines, and it turns on these transcription factors, and the process of hematopoiesis happens. In an adult, the site is flat bones and ends of long bones. So, the pelvic bones, they're flat bones, and they're site of active hematopoiesis. The sternum is site of active hematopoiesis. And then again, the terminal ends of femur and tibia can be very active sites of hematopoiesis as well. So some of these sites are easily accessible and can be used for evaluation of hematopoiesis. And then the trigger for doing a bone marrow evaluation on an individual is alterations in the numerical values in the peripheral blood. And sometimes that numerical value alteration results in assessment of morphology of peripheral blood, where we can identify abnormal elements. So immature cells that don't normally belong in the peripheral blood can be present. These would be cells like blasts or nucleated red cells or other cells. Or there can be abnormal morphology, so morphologic dysplasia and neutrophils. We'll talk a little bit about that. And so all of that would trigger an evaluation of the bone marrow. Now, these alterations and perturbations can be intrinsic to the bone marrow. So, for example, when we have a hematologic malignancy like acute leukemia or myelodysplastic syndrome, it's a problem associated with the bone marrow, results in these abnormalities in the peripheral blood. Or they can be extrinsic. So, for example, if somebody's had trauma and blood loss, the bone marrow will respond to that by turning out more red cell precursors. And you can see sometimes nucleated red cells as a compensating mechanism. So you can see many more polychromatophils in the peripheral blood. And all of these, again, are abnormalities that are perceived in the peripheral blood and may trigger a bone marrow examination. And the way once the bone marrow has been done, we evaluate the morphology to see what the problems are, where the problems are, and get some insight into the pathogenesis of the disease that we're seeing in the peripheral blood. So I said the pelvic bone, it's a flat bone, it's a site of active hematopoiesis, and the iliac crest is very accessible. If you put your finger behind your back, you will actually be able to palpate your own iliac crest, and that's the site of bone marrow biopsy. And if you are at an institution where the pathologist and the residents do a biopsy, you probably have done it and are probably a little bit more experienced than I am at doing this procedure. The posterior iliac crest is the most commonly biopsied site, although sometimes the sternum may be used as well. And when the sternum is the site of the procedure, we never get a core biopsy, we only get aspirates. In general, when I do a bone marrow evaluation, the assessment involves looking at the peripheral blood because that's what has triggered this entire examination. I do look at the bone marrow biopsy, but that will be covered in one of your later topics, I think a week from today. And then we will focus primarily on the cytomorphology that we see on bone marrow aspirates. What do these look like? So this is the JV needle that is placed into the iliac crest to obtain a core that looks like this. This is then formalin fixed. It's decalcified, most frequently in acid, but sometimes at some institutions, including ours, it may be decalcified in EDTA so that the DNA and RNA is preserved and can be used for molecular evaluation subsequently. That formalin-fixed paraffin-embedded tissue is then sectioned and stained with hematoxylin and eosin stains, and this is what a normal bone marrow would look like. This core biopsy can also be used to make touch imprints, the way you see here at the bottom, where you just gently tap the core on a glass slide and then stained it with a Romanowski stain to get a good cytomorphology, particularly in instances where you cannot get an aspirate because the bone marrow is fibrotic or too packed for somebody to be able to get an aspirate. What does an aspirate look like? It's a very similar needle, and the difference is that instead of taking out a core of bone, you put a syringe over here and you aspirate out, you pull out with the syringe the bone marrow, and then you make a smear on a glass slide that looks like this. And unlike the core biopsy, this is stained by a Romanowski stain, such as Giemsa or Wright Giemsa, and this is what the distribution of cells looks like on a well-spread smear. And the Romanowski stains really provide good cytoplasmic detail, especially when you're trying to evaluate for dysplasia and some detail that is critical to the diagnosis. The Giemsa and the Wright Giemsa stains are the most appropriate stains for that. You don't get that cytoplasmic detail in a hematoxylin stain. So this is what a case for me would look like. You have a peripheral blood smear. We have 4 levels from the core biopsy. We have 2 well-speculated aspirate smears. We routinely do an iron stain, a Persian blue stain on all our aspirate smears because most of our patients are adults, and it's just part of the routine workup here. This slide you see here is a reticulin stain. It allows us to assess for bone marrow fibrosis. This is a touch preparation made from the core biopsy, so it really recapitulates the findings here. Sorry, I'm getting a few pop-ups from this program, but that's okay. So this is the touch preparation here. And again, this is, again, stained by a Giemsa stain, so you get the cytomorphology that corresponds to what you're seeing on your H&E stain here. Then this last slide here is actually a clot particle. So you have these spicules on this slide here, and whatever's left at the end of the procedure is then put in a mesh bag. It's fixed in formalin. The advantage here is that when you have cells here, this is never going to be decalcified, and it provides really good material for any molecular studies that you might have to do on archived material 6 months, 8 months, 10 months, or even several years after the procedure has been done for research purposes. So this is a good source of preserved nucleic acids here. And then obviously this would be complemented by ancillary studies. At our institution, we report the flow cytometry with the bone marrow, so it's the same pathologist who's interpreting the bone marrow who interprets flow cytometry. In different institutions, this may be done differently, and so sometimes the aspirate comes out on one day, and the aspirate and the flow cytometry gets signed out, and the core comes out the next day and signed out by a different pathologist. And the genetic studies invariably come back with a lag time, sometimes of 3-4 days, sometimes up to 2 weeks, depending on what is being requested. But if you look at the current classifications of the hematologic malignancies, you'll see that there is more and more reliance on these ancillary studies. Flow cytometry has been a part of interpretation of bone marrows for a very long time. You can't tell a B cell from a T cell just by looking at the morphology, and you rely on flow cytometry to do that. And then genetic studies are more and more integral to appropriately classifying various entities. But in terms of morphology, this is the tray. This is what a tray would look like for any given case on a day when I'm signing out. I've already mentioned that Romanowski stains such as Giemsa stain provide the best nuclear and cytoplasmic detail and are very helpful in looking at the chromatin pattern, looking at the nuclei, but more importantly, when you're trying to assess dysplasia, looking at the cytoplasmic detail. As you can see here, there are several particles on the slide. You have a spicule here, you have another spicule here, another spicule here, and another spicule here, and another one here. So this is a very adequate specimen, and we look at the whole slide that corresponds to this image in just a second. But for you to be able to confidently rule in or rule out a diagnosis, you have to have a good quality specimen. We don't always get it, but and it's not that if I don't have a slide that looks like that, I will not interpret it, but I will interpret it with some caveats that make clear what the limitations for that assessment were. So we'll just go to the whole slide as if it was under the microscope, because I think to be able to interpret morphology, you have to be in the right part of the slide to be able to appreciate all the cellular details that you need. So again, a very well speculated, very well spread smear, I should say, and these are the slides that are a pleasure to look at. The whole slide scanning for bone marrow slides is not as nice as it is for some of the histology slides. So I have a combination of stills and whole slides. So for example, if you were to focus on this area here, you can see there are several things going on here. Right now, we are in the middle of the spicule. It's a very thick portion of the smear. There is absolutely no cytologic detail that you can get from this area, but you can appreciate the fat cells. They are part of the milieu of the bone marrow. They provide the niche for the hematopoietic cell development, and you can see them here. If you look carefully, you might be able to appreciate some vessels and endothelial cells as well. Again, part of the milieu and the stroma of the bone marrow. So this tells you that you have a good quality specimen. It doesn't give you any idea of what the cells in this area are. But as you move away from this spicule, you will see the cells here are very close to each other. They are well preserved, they are intact cells. And if you zoom in on that area, you will start appreciating the cytomorphologic detail a little bit better. So again, I apologize for the quality of these whole slide scans, but we have stills to get closer to these cells and appreciate the cytomorphology a little bit better. But a couple of things, even at this magnification, that stand out. You have a cell that looks like this, and I'm going to call on a picture and see if you have an idea of what this might be. Feel free to put your answer in the chat, and if any of the other participants want to put your answer in the chat, feel free to do that. This is the cell I'm pointing to, and if somebody wants to say what it is, erythroid. I think we don't quite know if this is megaloblastoid or normoblastic, but it is an erythroid precursor. And the reason you identify it as an erythroid precursor is it has this round nucleus with very condensed chromatin, and you can see the cytoplasm has this red tinge, which is very similar to the anucleate cells that are present here. So this has absolutely correctly been identified as an erythroid precursor. By contrast, you have several cells here that are much larger, and again, you can't appreciate the nuclear detail and the cytoplasmic detail as much, but there is no doubt in anybody's mind that this cell is very different from this cell. So here we have a bunch of myeloid precursors or granulocytic precursors that we will look at in closer detail. One more element that we should look at before we move out from this whole scan slide to close-ups is oh, sorry, is this better?
That's fine, thank you. Good.
Okay, yeah. So here we have a large cell with this very granular cytoplasm and a very lobulated nucleus. And again, in the chat, people are correctly identifying this as a megakaryocyte. This is the larger cell in the bone marrow, and you can really appreciate it from low power. And then we have some other cells that stand out, like this basophil here. And again, as you move away from this spicule, you will start seeing some smut cells that are not intact that cannot be used for assessment of morphology. So this is the best part of the smear that you want to evaluate and assess your morphology. And this is also the part of the slide that you would do your cell count. And my recommendation is, if you are going to evaluate a bone marrow for a myeloid malignancy or leukemia or an MDS, take the time to do a 500 cell count. It will make you commit to the morphology of the cells. And then for entities where the blast count is important, or when the monocyte count is important, the monoblast count is important, you will get a much more.
One of our students, Kriti, mentions in the chat that this megakaryocyte has an emperipolysis.
Yes, that's an excellent observation. So what megakaryocytes do is, as they develop, they wrap their cytoplasm around these other cells in the bone marrow, and these cells just sit there. It's not a pathologic finding, and you may see some correlations with some disease entities, but it's a fairly normal finding, and we see it often. And this should be distinguished from phenomena like hemophagocytosis, which has happened, where the cell that is chewing up the live cells and destroying them is a histiocyte and a macrophage. So unlike that, this is a peripoiesis, where the intact cells are just sitting inside the cytoplasm of this megakaryocyte. Excellent observation. Moving on. So this is the ontogeny of the granulocytic cells, and this is pretty well described, very well delineated. You can appreciate all of these cells in a good slide, and you have on the left a blast, which is an undifferentiated cell. It has a high nuclear cytoplasmic ratio. There's a little ring of cytoplasm that may or may not have granules. You have this open chromatin, you have these very prominent nuclei. As it starts maturing into a promyelocyte, you have the appearance of these coarse, large basophilic granules, and as the cell matures a little bit further, you have the development of these pinkish purple secondary granules. It's sometimes referred to as the dawn of neutrophilia, where this cell is now committed to becoming a neutrophil. There are still some primary granules in the background, but most of the granules that you see here are these fine secondary granules that will stay in the cell through its life. So you have a myelocyte where the nucleus is still round, maybe a little bit indented, but still acquired. It takes up about 2/3 of the space within the cell. And then the nucleus starts shrinking and becoming more compact. The chromatin starts condensing. So here you have this finely dispersed open chromatin. You may even appreciate some nuclei. In contrast, here the nucleus has started to condense, and the nucleus is also becoming very indented, and it's on its way to becoming a mature neutrophil. And the earliest recognizable neutrophil, or not the earliest recognizable neutrophil, but the form that we sometimes see in the peripheral blood is this band form, which has this band-like nucleus, and eventually the nucleus starts segmenting into lobes, and the predominant population of neutrophils in the peripheral blood are these segmented neutrophils. Again, so I've taken these individual snapshots and laid them out in this. You will never see them looking like this in a bone marrow aspirate, and what you are more likely to see are fields like this. And so again, you have just a snapshot from the slide that we were looking at before, the whole slide that we were looking at before, where you can really track the entire ontogeny of this cell, starting from this myelocyte here to a metamyelocyte here, another metamyelocyte here, then turning into a band, and then a segmented neutrophil here. So this is one field of that slide. Here's another field where you can start with a blast, and you have a promyelocyte with some primary granules, and then some myelocytes here, and a metamyelocyte, and then this has now a very well-defined round lobe, so this is a bilobe cell. There's still some persistence of this band-like remnant of the nucleus, but again, an illustrative field that shows neutrophil maturation here. A similar process happens to eosinophils. You have a mature eosinophil here, and then you have some eosinophilic myelocytes over here. Obviously, these are not as numerous as the neutrophil precursors, but in certain situations, you can see the maturation process for the eosinophils as well. And I'd really like you to pay attention to the granules. They are coarse and large, but they are very pink in color, unlike the granules that we're seeing in the neutrophils, or you can see them here, for example, that are much finer and more pinkish purple than these coarse pink granules. Basophils, they're rare cells, but you can appreciate that there is some nuclear segmentation here as well. The granules are blue in color, they're coarse, and they almost take over the entire volume of the cell, so much so that they're lying on top of this nucleus, and the nuclear outline is not very well defined, and the chromatin is somewhat smudgy, not as crisp as it is for eosinophils and neutrophils. This is a mast cell that looks very similar to a basophil, except you can see that the nucleus here is a single round nucleus, and again, you have a lot of coarse granules that are present in the cytoplasm. Monocytes. I find this a difficult cell to identify in the bone marrow, and I think we are notorious for undercounting the monocytes. In the olden days, people used to do enzyme cytochemistries using non-specific acetate like alpha-naphthyl acetate or alpha-naphthyl butyrate, and there are enzymes that are present in the cytoplasm of these cells that have a Brown reaction with that substrate. And when we used to rely on enumeration of these monocytes for certain diagnoses, that stain was very important. Now more people rely on flow cytometry and other techniques to do that enumeration, which has its own limitation, but is a reasonable surrogate. But that's what the monocyte looks like. It has more bluish-gray cytoplasm, and even in this cell, which is somewhat immature, you can see that there is a lot of nuclear folding for this cell. So these are some of the normal myeloid elements in the bone marrow. Moving on to the erythroid precursors, this pronormal blast, which can sometimes be difficult to distinguish from a myeloid blast, is the earliest recognizable erythroid precursor in the bone marrow. What I find very helpful is to pay attention to the cytoplasm. For the erythroid precursors for the pronormal blast, the cytoplasm is very, very dark blue. Sometimes you do see a little bit of a Golgi zone. And then I don't know how much you can appreciate it on your screens, but they have these very bar-shaped or comma-shaped nuclei that are adherent to the nuclear membrane sometimes, and many prominent nuclei in general. So a pronormal blast here, as the cell matures, it starts to acquire some hemoglobin, and it starts turning pink, just like the anucleate red cells in the field. And the chromatin starts to condense and becomes very compact. The blue color comes from the ribosomes and the RNA that is still present in the cytoplasm as it's actively synthesizing protein. And then as that transcription or the translation goes down with the maturation of the red cell, the cell turns more and more pink and starts to look like a mature red cell. And so I have two fields here showing various stages of erythroid maturation. They're not as well delineated morphologically as the neutrophil maturation, so we tend to count erythroid precursors as a single entity and not make a distinction between various stages of maturation, although in the older classifications, the enumeration of the pronormal blast or the erythroblast was important to get to certain diagnoses. That entity has mostly gone away in the current classification scheme, so we really don't make this distinction. The other cell, which sometimes the residents and trainees struggle with, and sometimes I struggle with as well, is this plasma cell, and how to distinguish it from some of the erythroid precursors, because they can both have blue cytoplasm, the compact chromatin here, but you can see that this is a much larger cell. The nucleus is more eccentrically placed in contrast to this erythroid precursor here, which even though it has a lot of blue, is starting to accumulate some pink and can be distinguished from the plasma cell that's lying next to it. So a plasma cell here, and erythroid precursor here. And again, this brings up another point that I want to make. If you're struggling to classify a particular cell, find a cell in the same field that you're very, very comfortable with and compare and contrast and see how many features match up. And sometimes it will help you in classifying that cell appropriately. And I think at this point in time, I do want to ask one more question. Feel free to put your answers in the chat. Do people recognize this cell? Over here. Very good. It is a lymphocyte, and again, sometimes when there are many reactive lymphocytes present in some conditions, they can be a little bit challenging as well because of the basophilic cytoplasm to distinguish from some of the erythroid precursors. But we'll keep the cell in mind as we go through the rest of the presentation because we'll come back to it on more than one occasion. Finally, we saw the megakaryocyte from low magnification. Here you have a mature megakaryocyte. It is the largest cell in the bone marrow. It has this lobulated nucleus. The ploidy of these megakaryocytes is very high because they develop with this process of endoreplication, where the nuclear material keeps multiplying, but the cell doesn't divide into multiple cells. It just forms its nuclear membrane, and you can get a ploidy of as high as 64 and sometimes 128 N as well. In a mature megakaryocytes, there is a formation of this demarcation membrane system that has this packaging of the granules within them, and then from the ends of these demarcation membranes, there is shedding of platelets that come out into the peripheral circulation. The less mature, and actually you can see some of that happening here. You have these platelets budding off of this somewhat immature megakaryocyte. We haven't quite gotten to hematogones yet, not in this field, but we have this immature megakaryocyte here, which has much more dark blue cytoplasm, and this should not, and it's so dark that it's obscuring the nuclear detail. These smaller megakaryocytes that are blue sometimes may have non-lobated nuclei, and they shouldn't be considered as dysplastic. They are immature, and you recognize the immaturity by the presence of this really dark blue cytoplasm. Now we're coming to hematogones. So we have a lymphocyte in this field here, which looks like a mature lymphocyte, the one that we saw, very similar to the one we saw in the previous smear. And you can see that there are some cells in this field that are a little bit larger. They have what I describe as uniformly dispersed chromatin. There is no nucleolus in this cell, and the nucleus is very round. The nuclear cytoplasmic ratio is very high, just as it would be for a blast. You can see there's a little rim of blue cytoplasm here, but for the most part, it's hard to appreciate the cytoplasm. What helps in distinguishing the cell even morphologically from a blast is it is present in a certain environment. So you have this larger lymphoid cell here with very uniformly dispersed chromatin, almost blast-like, and you can see within the same field there's a progression. So you have the cell, a smaller cell, still with fairly open chromatin, not quite as condensed, and then you have a little bit of a spectrum of maturation here. And in this field, right at the bottom right, you can see a cell that starts to look like a mature lymphocyte that you would see in the peripheral blood with very compact chromatin and round nuclei. And of course, this is something you will encounter, particularly if you're looking at pediatric bone marrow. So these hematogones are B-cell precursors. The B-cell maturation happens in the bone marrow, and the precursors are present in the bone marrow. And in pediatric patients, particularly before the age of 1 year, they can be so abundant, they can be 40 to 50% of the bone marrow cellularity. And when the differential diagnosis for the patient is B-lymphoblastic leukemia, this can be very challenging. They do have a very distinct pattern of maturation on flow cytometry that I won't be going into today because you haven't had your flow cytometry lectures yet. So if you're struggling with morphology, you will definitely be able to distinguish them based on their very distinct maturation pattern of flow cytometry. Of course, the problem is when you're looking at a post-therapy marrow in a pediatric patient where the hematogones are present along sometimes with residual disease, you have to be very, very careful in making that distinction. Again, I rely very heavily on flow cytometry to do that. Morphology may not always help you with that, but this is the normal B-cell precursor that's also referred to as a hematogone that you can encounter in the bone marrow of pediatric patients or patients that are recovering from transplant or sometimes just chemotherapy. So that was the normal, and I can pause here for a second or two if people have any questions. If not, we will continue with the abnormal. So abnormal can be presence of increased blasts. They can be present, so precursor cells that are increasing numbers. And again, you have to enumerate them. You have to assign a lineage to them, whether they're myeloid or lymphoid, to figure out what the pathology and the problem of the bone marrow is. The other aspect of abnormalities are morphologic dysplasia. So we've looked at what a normal precursor cell looks like, what a normal neutrophil looks like, what a normal megakaryocyte looks like. And then there are certain situations like myelodysplastic syndromes where you have accumulation of abnormal cells. And sometimes you have accumulation of morphologically abnormal cells or cells that look dysplastic, even in reactive conditions. So the red cell precursors can be very abnormal in B12 deficiency or copper deficiency or zinc toxicity. Neutrophil morphology can be abnormal in patients receiving certain type of drugs. So you really have to be very careful in interpreting the significance of morphologic findings, and we rely very heavily on clinical history. We have access to the electronic medical records of these patients, and we sometimes spend a lot of time digging through it, trying to figure out if the morphologic change that we're seeing is reflective of a malignancy or if it is secondary to something else that's going on in the patient's medical record unrelated to bone marrow pathology. Increased blasts determine the lineage, morphologic assessment of maturing cells, whether they're maturing normally or whether there's dysplasia. And are there any abnormal components, like abnormal lymphoid aggregates that are present in big chunks or that are present in specific locations, particularly when you're evaluating the core biopsy or the intrasinusoidal or peritrabecular. So that's when the core biopsy becomes very, very critical for assessing the significance of these lymphoid cells. Plasma cells, when they're increased, you could again be dealing with something reactive, or you could be dealing with the malignancy of plasma cells. You could be even dealing with the malignancy of lymphoid cells that differentiate into plasma cells and have this lymphoplasmacytoid morphology. You can sometimes see metastatic tumors on aspirate smears, particularly in neuroblastoma patients. You can see them come out on the aspirate. But other metastatic malignancies like metastatic breast cancer or metastatic prostate cancer, there's usually a dysplastic reaction around the metastatic tumor. There's a lot of fibrosis, and these metastatic tumor cells don't come out into the aspirate. So I will not be talking about it today. I will restrict the conversation to, like somebody said, storage disorders. You also will see some abnormal histiocytes, and those will sometimes come out in the aspirate smears as well. But I think this morning I'm going to restrict our discussion to some blasts, some morphologic dysplasia, and some lymphoid and plasma cell pathologies. So here is some description of dysgranulopoiesis or abnormal neutrophils that can be present in patients who have myelodysplastic syndrome, and sometimes in patients who are receiving certain therapies. So just the presence of neutrophil dysplasia doesn't mean the patient has MDS. You have to interpret it in the clinical context, and more frequently in the context of some genetic data to get to a diagnosis of MDS. So evidence of dysgranulopoiesis or evidence of dysplasia in the neutrophil series particularly, they can either be they can either be small in size or they can be unusually large in size. Nuclear hypolobation, so they can have this very compact chromatin that looks like it's a chromatin of a mature neutrophil, but there's no nuclear lobation here. There's an example of that here. There's an example of that here. And like somebody pointed out in the chat, there's this very distinct bilobe cell, which is referred to as pseudopelvic Huey cell. So nuclear hypolobation is indicative of abnormal maturation of neutrophils and can be seen in myelodysplastic syndromes. Irregular hypersegmentation. I don't have an example of that in the images that I have here, but sometimes you can get nuclear twinning and the cells can have 6 lobes or 8 lobes just because the nucleus again is endoreplicated without the cell division happening for that cell. Decreased granules, so you can see here there's a relatively well-granulated neutrophil precursor present, and by contrast, the cytoplasm of this neutrophil is very pale and devoid of any granules. Here's another example of an hypogranular another example of hypogranular cytoplasm which would be present in myelodysplastic syndrome. And somebody pointed out the presence of giant myelocytes and metamyelocytes in B12 deficiency and folic acid deficiency as well. That's absolutely correct. And then pseudo-Chetti-Kakashi granules, again, you have some abnormal lysosomes present within these cells that make these giant granules. I don't have an example of that in this illustration either, but you can sometimes see that, and that's within the spectrum of morphologic changes that one sees in myelodysplastic syndrome. Our rods are never normal, so anytime you see that, most of the time you will see them in blasts in the context of acute leukemias, but sometimes you can see them in myelocytes and more mature cells as well, and they're never normal and always suggestive of abnormal hematopoiesis. You actually don't see them in reactive conditions. Yeah.
Sorry to interrupt you. Sandeep, can you use your pen and show them the dyspoetic myeloid cells? If you can use your pen, if you don't mind.
Yeah, not at all.
Thank you.
So let me walk you through one more time. So here, let's start off with a relatively normal granulocytic precursor. It has nuclear chromatin that seems to be reasonably condensed for a stage of maturation. You can appreciate some pink purple granules in the cytoplasm. If you contrast that to the cell just below it, the chromatin is much darker, even though there are no separate well-defined lobes. And then compared to the cytoplasm here, you see no granules. It's just very pink and pale. And then you have this little thing sticking out of the nucleus that would be referred to as a nuclear excrescence. This can be, it's a very non-specific finding. You can see it in patients who have aging hematopoiesis, but it is also frequently seen in patients who have myelodysplastic syndrome. Here's another example of this nuclear cytoplasmic asynchrony or dysplastic neutrophil maturation. You have a cell that looks like myelocyte. It has this large round nucleus, but the chromatin is very, very condensed, so there's abnormal nuclear condensation. And you have cytoplasm that is very pale and pink and without any granules. Then you have another example here. And the nuclear excrescences do not mimic bar bodies. I don't have an example of bar body here, but the bar bodies are perfectly round, very well defined elements that you see in patients who have XX chromosome complement. They're usually very distinct. They're not this fine. They're this perfect round projection sticking out of the nucleus. So moving back to this cell here, this has these two very, very condensed nuclear lobes, and again, cytoplasmic hypergranularity. So nuclear hypolobation, abnormal chromatin condensation, cytoplasmic hypergranularity are all features of granulocytic dysplasia. Moving on to dyserythropoiesis or erythroid dysplasia, really the most common thing that stands out, and you will see it more often than not if you're dealing with a patient with myelodysplastic syndrome, are the nuclear abnormalities. So you can see that there's nuclear budding, there's this nuclear lobe here, and another nuclear lobe. Can people see my arrow?
Yes, sir.
Okay, so there's a nuclear lobe that is budding here, and it's referred to as nuclear budding. Internuclear bridging is harder to appreciate. I do not have an illustration of that, but what it means is you can have two red cell precursors lying side by side, and there is a fine strand of chromatin that's bridging these two nuclear lobes. You don't see it here, but that's what it would look like. Karyorrhexis, the cell is falling apart in the process of mitosis. Multinuclearity, again, you can see very large lobes present in the single red cell precursor. Nuclear hyperlobation, again, less commonly seen, but can be part of dyserythropoiesis. You can also see this nuclear hyperlobation in certain types of congenital dyserythropoietic anemias. Megaloblastic changes, again, not necessarily illustrated on this slide, but we will see some examples later on. You have very large nuclei that are still like very open chromatin, and the cytoplasm has matured with a lot of hemoglobinization and something that's very non-specific. You see it in vitro folic acid deficiency, but you can also see these megaloblastic changes in myelodysplastic syndrome. And then cytoplasmic vacuoles, again, is a non-specific finding. You can see it in copper deficiency and zinc toxicity. You can see it with certain drugs, but you can also see it in myelodysplastic syndrome. And ring sideroblast, this is an abnormality you will see if you use a Persian blue stain. Normally, you may see one or two siderotic granules of iron present in the cytoplasm of the nucleated red cells, but when you start seeing these rings that are present around the periphery of the nucleus, that's referred to as ring sideroblast. Again, a non-specific finding that you can see in elect toxicity and some other benign conditions, but you can also see it in some very specific types of myelodysplastic syndrome, particularly those that have SF3B1 mutation, where the disease has a very distinct clinical behavior and is responsive to certain types of targeted therapy. So it is suggestive of erythroid dysplasia, but a non-specific finding and can be seen in multiple different entities, including myelodysplastic syndromes that have an SF3B1 mutation. Moving on to megakaryocytic dysplasia, if you remember, our normal megakaryocytes, they're large cells with lobated nuclei that are all connected to each other, and the cytoplasm is granular, and I describe it as fluffy. I describe it like a cotton candy cytoplasm almost. In contrast, the dysplastic pond ball appearance is this is what is referred to as a pond ball appearance, where you have these very widely separated nuclear lobes. They're almost like fish eyes on either side of the fish's face, and you have cytoplasm between. These are usually smaller in size, and you have a micromegakaryocyte here, which is the size of the myelocyte that's present in the field. And again, something you see in myelodysplastic syndrome. These small megakaryocytes usually have non-lobated or hypolobated nuclei as well, and then, like somebody pointed out, the pond ball nuclei that are widely separated nuclear lobes. So all of these are suggestive of megakaryocytic dysplasia or dysmegakaryopoiesis. So with that, we will move on to some very specific cases, and this was my goal to provide these slides to you ahead of time, but I wasn't able to do that. I apologize. And so let's look at them together and see if we can figure out what is going on in some of these cases. So again, this is not as well speculated as our other slide, but you still have some spicules here. The way this slide has scanned, if I go close to this area, it's not in focus. So I'm going to focus on this area where the slides are much better separated and we have some cytoplasmic detail. And maybe CPU usage is high. Okay, that's fine. So for example, here, or I'm going to find a better area. Just give me 1 second. So I think this is probably as far as this is going to get. And I'm going to call on Pallavi to see what you think these cells might be and what is your morphologic description. Pallavi, are you there?
Yes, sir. Yes.
Sandeep, can you go further higher for this?
I will in just a second, but I want somebody to give me some opinion at this magnification. We're at 40x, and I think we should have some sense of what is going on here, and then we'll go to higher magnification.
Erythroid, I mean.
You think they're erythroid? Okay. When you're thinking about erythroid, what is it that you look for in the cytoplasm? It's very blue, right? The cytoplasm for the erythroid precursors would be very blue. This is not quite as blue. And we have a small lymphocyte here, so they're just a little bit larger than the size of that small lymphocyte. And the nuclear cytoplasmic ratio is very high. Over here, you can see a little bit of a cytoplasm here, but for the most part, the entire cell volume is occupied by this nucleus. We do have a mitotic figure in the field, which in the bone marrow doesn't mean a lot. But in this case, where you have no normal hematopoietic elements, you have cells that all look very similar to each other. We're dealing with an abnormal condition because the cytoplasm is not blue, the nuclei are not very prominent. I don't think these are erythroid precursors. And there's a lot of traffic in the chat that implies that these are blasts, which is correct. And the next question would be, the smut cells, no, they are very preserved cells. You can see the cytoplasm in almost all of them. Does anybody want to venture a guess as to what type of blast these are? And then I will go to higher magnification on Still's lymphoid. So very good. Yeah, excellent. So why do we say they're lymphoblasts? So here on the left, I have a normal image from a person who has some hematogones, just so that you can compare the difference between the nuclear chromatin and the cytomorphology of the hematogone from a lymphoblast. And then you have some mature lymphocytes in this field to compare and contrast them as well. So again, this is a still from the slide that we looked at low power, and the quality here is obviously better because I've been able to take a better picture. And you can see that this is an intermediate sized cell. It doesn't have the finely dispersed chromatin that we see in the myeloid blast, and we'll see the example in a minute. But it has this, what I describe as uniformly condensed or uniformly dispersed chromatin. For the most part, you cannot appreciate the nuclei, although there are some blasts where you can see that there is a nucleolus present. When you do appreciate the cytoplasm, it is blue in color, it's without granules. The other feature which is very helpful in looking at these lymphoblasts is that they are almost pushing at the boundary of the cytoplasm. So I describe this as bulging nuclei. And this happens to be an example of a hyperdiploid BLL, which means that you have triploidies of several chromosomes. In this particular case, they were for chromosome 4 and 10. And that's a common genetic subgroup that you see in the pediatric age group. More often than not, I see this morphology in association with a hyperdiploid BLL. I'm not going to show you the flow plots today, but the flow cytometry did show the appropriate immunophenotype with CD19 expression, which is a B cell antigen expression of TDT, which is seen in precursor B cells and precursor T cells, and CD34 and CD10. So very typical morphology, very typical immunophenotype. And again, your clue, if you go back to the previous slide, and I think most of you had it, is there's absence of any normal hematopoiesis no matter where you look, even in areas where you can't appreciate the cellular detail. You don't see any granulopoiesis, you don't see any megakaryocytes, so you know that this is an abnormal bone marrow. Somebody was mentioning smudge cells, so that's what the smudge cells would look like, and there weren't any in the field that I was in. But absence of residual hematopoiesis, presence of this very uniform population of intermediate sized cell, and I think that most of you guys had it as acute leukemia, and then as we look at it at higher magnification, we are able to identify several cytomorphologic details that help us assign lymphoid lineage to these cases. Of course, at our institution and most hospitals in the United States, this would have to be confirmed by flow cytometry. And then it's good to have that footprint to follow these blasts post-therapy to look for low levels of measurable disease that might be present after therapy. So here I don't have a whole slide image, but on the right side I have the normal counterpart of these cells, and then here I have some abnormal findings. So a low power magnification. Does anybody want to give me some idea of what they think this might be? First of all, can we recognize this normal cell?
Promyelocyte.
It's a promyelocyte. Very good. So several people have said APL in the chat, and that's exactly what this is. You have these very distinct bilobe nuclei, almost double shaped. Sometimes people describe them as coin on coin. And if you look at this at higher magnification, they have these very coarse abnormal granules. And then in other cells, you can see this indentation in the nucleus, and very distinct. You don't see this very often. You can see it in some cases where you have multiple hour rods, which are these purplish, pinkish rod-shaped structures present in the cytoplasm of the cell. And in this case, they happen to be multiple hour rods in a cell, which is something you see only in acute promyelocytic leukemia. So this is associated again with a very specific translocation that results in generation of a chimeric protein, the BML-RARA protein, which is responsible for pathogenesis of this leukemia, and is now the basis for using targeted therapy, where you don't use any chemotherapy to treat these APL patients for the most part, and they respond very nicely to all transretinoic acid as well as arsenic trioxide. So an example of acute promyelocytic leukemia. Again, most of you knew what this was. That's excellent. So moving on to the next case. So what are some of the features that stand out in this particular case? Does anybody want to put that in the chat? Or should I call on a name? Yojita, do you want to describe this case?
Sir, I'm saying eccentric nucleus with basophilic cytoplasm.
In the cell? And the cell? Yeah, okay.
Yes, sir.
So do you want to assign a lineage to the cell?
Yes, sir. I'm thinking megakaryocyte lineage, sir.
Very good. Okay. And so that's one thing. And are these normal or abnormal?
They're abnormal, sir. They're hypolobulated and absence of cytoplasmic granularity.
Okay, so they're dysplastic megakaryocytes?
Yes, sir.
Okay, and what else is going on in the background? What are all these cells?
Sir, they're looking like erythroblast lineage.
We'll come to the lineage at a higher magnification, but they're immature cells, right? So they're blasts.
Yes, sir. Immature cells, sir.
Okay, so you have some megakaryocytic dysplasia, you have some blasts here. Somebody's put hand mirror cells in the chat. I really don't pay any attention to that. So for example, this cell here could potentially be considered a hand mirror cell, or this cell could be considered a hand mirror cell. But you can see that these cells are in a minority for the most part. Your cells around. And the chromatin, compared to the B lymphoblastic leukemia case that we saw earlier, is much more finely dispersed. So it's very open chromatin. And again, there isn't any neutrophil maturation in this field. You don't see any segmented neutrophils. So you have a dysplastic megakaryocyte, you have a dysplastic megakaryocyte, and you have some blasts in the background. So let's go look at this at higher magnification and see if we can appreciate some of the features. So again, this is a close-up of the same field that we were looking at. And so here you start seeing some very specific aspects of the blast morphology. You have some lymphocytes in the field. You even have a nucleated red cell, which gives you some impression of the size of the cell. It's a large cell. It has very finely dispersed chromatin. Unlike the previous leukemia that we saw, you can almost see through the chromatin. It's very fine. A lot of these blasts have multiple nuclei. So there's a nucleolus here, there's another one here, another one here. And then you can start to see that some of these cells are starting to develop nuclear folds. This is suggestive of monocytic differentiation. So, and then you have a neutrophil in this field as well, which is dysplastic. So I think most people, and there's another neutrophil here where you have very hypergranular cytoplasm. So again, there's indication of background dysplastic hematopoiesis. You have blasts that are clearly more than 20%. So even using some of the older criteria for defining acute leukemia, this would meet the threshold of more than 20% blasts. There is presence of background dysplasia, very, very apparent in the megakaryocytes, but also present in some of the neutrophils. So there are several ways to classify this. And in the older classifications, this would be referred to as acute myeloid leukemia with myelodysplasia-related changes. We have started to move away a little bit from that classification because, again, most of the time, presence of these kind of dysplastic changes are associated with an aggressive disease and a bad outcome therapy. But there are some cases where you can see these dysplastic changes, and there are certain mutations that pull them out of that poor prognosis group, particularly mutations in transcription factors like CBP alpha, and sometimes you can see megakaryocytic dysplasia and NPL mutated leukemias as well. And then somebody also mentioned myelomonocytic leukemia. So there's not a unifying feature there. And so the revisions in the classifications have moved away from that morphologic description to a genetic-based classification. This person happened to have enough rearrangement, which is associated with a lot of background dysplasia. And so the classification would be based on that genetic entity. But at the very simple level, this would be an acute myeloid leukemia. As residents, I'm very happy to see that you guys are able to appreciate the background dysplasia. And so that would be the starting point for this, the diagnosis and classification of this disease is acute myeloid leukemia with some monocytic differentiation and maybe a lot of background dysplasia. But when you know the genetic findings, this becomes a little bit more, all of that falls into place and it becomes clear as to what this disease is. So just another example of acute myeloid leukemia, which in the current classifications would be defined based on the genetic entity, and you would be able to make a diagnosis even in the absence of 20% blast for this particular case. So moving on to the next case, and here we are not able to get a bone marrow aspirate, so what we are looking at are the touch imprints of the core biopsy. And let's zoom in to an area and see what are some of the things that stand out. And I'll find a better, I'll find a reasonably decent area so that we can look at it. And the reason I chose to keep these slides is because this is how your real sign out happens, right? You don't have a picture on the microscope. You have a slide. You have to find the right area to look at, and then you have to appreciate the morphology of the cells to get to a diagnosis. So how about this area? And maybe this time I'm going to pause in a second, and I'm going to call on Kriti. Kriti, do you want to describe what we are seeing here?
So this particular area consists of a heterogeneous group of cells, which is composed predominantly of myeloid lineage cells.
Myeloid lineage cells. So for example, all of these have a lot of granules, right? So you're right, they're myeloid lineage. What color are these granules?
So more eosinophilic as of
more eosinophilics, right? They're not fine granules, they're pinkish brown in color, and there are a lot of them, right? So you have a lot of eosinophils, both mature and immature. Do you see? Yeah, go ahead.
So most of these cells are myeloid series cells. Erythroid series cells are not so prominently seen in this field. And so also there's a sense of hypercellularity in this area.
There's a sense of hypercellularity. We don't know the age of the patient, so we don't know if this is maybe a young person or an old person. But yeah, it's a very cellular touch imprint. You're right about that. We're predominantly seeing eosinophils, eosinophil precursors. We're not seeing mature neutrophils. We're not seeing many erythroid precursors. So there is a certain abnormality, and you're absolutely right. And then one last question, and then we'll move to higher magnification and try and get to a better answer as to what this is. Any thoughts about what this cell might be over here?
So it looks more similar to a dysgranulopatic myeloid cell, but I can't be sure. So.
You can be sure because maybe we're not in a good part of the smear. Things don't look very well granulated. But I'm going to just keep pushing a little bit because I think it's good to try and review the material here. Any thoughts about this cell? And does anybody else want to comment on this cell? Maybe not Kriti, but somebody else. Zahid, do you want to comment on this cell?
Look like a monocyte cell.
It looks like a monocyte or a cell in the monocytic lineage. Maybe not entirely mature because the chromatin is fine. And here you do have another monocytic cell that's a little bit smaller. So maybe something in the monocytic cell. So we have a lot of blasts. There's a blast here. There's a blast here. Maybe an immature monocyte or a promonocyte. Another more mature monocyte and lots of eosinophils. So let's see what happens when we go to a better image. So here's a normal counterpart that I had shown in the earlier image. You have several cells that are, in the same size. They have this bluish gray cytoplasm, maybe some cytoplasmic vacuoles, very finely dispersed chromatin and these delicate nuclear folds. There's one here. There's another one here. There's another one here. There's another one here. So I would consider these cells as promonocytes, especially when you start seeing these very prominent nuclei. And for the purpose of classification of malignancies, these are considered as blast equivalents. So you can see these promonocytes here in addition to blasts. Clearly the blasts are more than 20%, but then there are all these eosinophils. And do they tell us anything about what this disease might be? And maybe in a second you will know what this is. So when you look carefully, most of the eosinophils look like this, but you have this rare eosinophil, which has some of these pinkish brown granules, but it also has these very coarse blue granules. Does anybody want to make a guess as to what this might be? Or what are we dealing with? A big share?
M4EO inversion 60.
Very good. So that's exactly what this is. And so I think this case, it's a little bit of a cliche, but it is also one of the cases where you have just as good a morphological relation with genetics as you have for APL. And so just to give you an idea that you spend some time on your slide and you can get very, very far just from looking at a Giemsa stain slide. Of course, a lot of the times you still need to confirm it by genetics, but it's really good practice to push yourself to find some of these uncommon cells and try and do some it correlates with the genetics and see how far you can get. So excellent. This is an acute myeloid leukemia with inversion 16, which is a translocation that results again in generation of a fusion protein, which is core binding factor beta, transcription factor involved in neutrophil maturation, and MYH11, one of the genetically defined entities in the WHO and the ICC that is characterized by the presence of these abnormal eosinophils. And the abnormal eosinophils are rare. This case has a particularly high number of eosinophils. Sometimes the eosinophils are not as prominent either, but if you spend some time looking at your slides, you will find these abnormal eosinophils. So moving on, and we are almost at the end. So just a little bit longer. Okay, so we're changing gears a little bit. Who hasn't spoken? Pallavi, have you had a case yet?
Yes, sir.
Do you want to take another one? Are you the person who hasn't seen any bone marrows? Am I just calling on you? There was one person who hasn't had any bone marrow experience.
Amita, I think Amita has not spoken as yet. Amita, maybe.
Yes,
Amita. Okay.
And Shruti too. Amita and Shruti.
All right. Amita, Shruti, Naseha, whoever wants to take this case.
So, erythroid lineage cells are there, sir.
Okay. So, all right, let's focus on this area here for a minute and see what we can do about the lineage. So what do you think this cell is?
Intermediate normoblast, sir.
Intermediate normoblast or an erythroid precursor, right? So do these cells look similar or are they different from the cell?
They are different, sir.
They're different, right? So do we want to revisit the lineage?
Sure.
Lymphoid or myeloid? Let's start there.
lineage.
Lymphoid lineage. Okay, so this is maybe an entity that one doesn't encounter very often in India, but it is the commonest malignancy that we encounter in the Western Hemisphere, particularly in the United States. So these are lymphoid cells. Unlike normal mature lymphocytes, they have chromatin that's really, really clumpy. So for example, if you compare it to this cell here, the chromatin here is very clumpy, and it's referred to as, chocolate chip cookie or cracked earth. So if you go into Rajasthan and it's very, very dry, you look at the earth, that's the appearance of the earth. So cracked earth, chocolate chip cookie, soccer ball, golf ball, whatever you want to describe it as. And the cell is relatively small. It's very uniform. Pretty much whatever you see, they're all uniform in size. And there's several people who've put in the chat CLL as a diagnosis, which is absolutely correct. And again, just for comparing and contrasting, these are your erythroid precursors. They have this distinct pink cytoplasm with a tinge of blue, and contrast that to this blue cytoplasm in a cell that I agree has a very comparable nucleus, but that's the distinction you want to make by careful morphologic assessment. And here is, excuse me, a higher magnification of this. Again, you see these very round cells with very clumped chromatin. And again, you have an erythroid precursor here, just to compare. You have another erythroid precursor here, an early precursor. So both stages of maturation, and compare and contrast these cells, which are with very little cytoplasm that's blue in color. And then you have a cell here, which is again fairly frequently seen in small percentages at least, and this is a pro-lymphocyte here. This is the punched out nucleus with fairly abundant blue cytoplasm. So a good example of chronic lymphocytic leukemia involving the bone marrow. And I think a lot of people had it in the chat. So the last case that we are going to see is this one. Let me see if let's start here. Is this normal or abnormal? Anything that jumps out? Not really, right? So you have some erythroid precursors, you have some megakaryocytes buried in this, you have some neutrophils here that seem to be maturing normally. So we'll move away from this field and see if we can find a different field. So here we have a different field. And the reason I picked up this slide is to just show you that there are certain conditions that will have a patchy involvement. And again, you have to spend some time looking at your cases. You have to really be mindful of the clinical history here. And there are already many, many people in the chat. They are pointing out that this is multiple myeloma. And again, you have this eccentric nucleus. And actually, I'm just going to move on to the next slide so we have a higher magnification of that. I wouldn't call these plasmablasts. They still have mostly clumpy chromatin, although a lot of them have prominent nuclei. I would say this is still just a plasma cell malignancy or multiple myeloma. And in this particular case, we have the immunophenotype confirmation of that. These are 38 and 138 positive cells that don't express CD19. They have a variant expression of CD56, and they were kappa light chain restricted. So you can sort of see the most mature plasma cell here, and you can track the similarities to that cell and the other cells present in the field. So this is my last slide and my last case. I think I used up more time than I thought I would, but it was really wonderful spending the morning with all of you. And with that, I think I'm going to stop sharing my screen, and so I can see all the faces again, and I'm happy to answer any questions.
Hi, Sandeep, thank you very much. Excellent class. We have Dr. Rajiv with us. Sir, you are there. Sir, would you like to make any comments on the talk or anything which you would like to add?
Thank you, Sandeep. This was a very good introduction to morphology. I just want to go back to the slide of hematochrome that was showed. No, it was lymphocytes and precursors. Can you hear me?
Yeah. Give me 1 second. I will share my. Actually, sorry, it may take me a second to get to that slide, but I'll just pull it up in a second.
You want to say something about hematocytes in the meantime? You can Sandeep brings the slides.
Nice.
Yeah, in the meantime, when Sandeep is trying, the hematocones are confused with blasts. So that is the major interest of we pathologists. So how do you differentiate? Sandeep has told you, Dr. Rajiv will tell you more. If you have a problem like we have, mostly we do it for MRDs. When we have measurable residual disease in the case of ALLs, there you need to differentiate those blast-looking cells. So there we take help of flow. Morphology is helpful. Yes.
This one. Yeah, this one. I would like to, many of the students would like to say why these are hematocones. What have they learned, especially those who have never seen? Because I think this is a very, very good slide for introducing hematocones. Very, very, very chosen slide.
Thank you. Yeah. So what I really want.
I was asking any of the students would like to volunteer answers. The teaching is done, and now I just want to know how.
Make it full screen. Sandeep, full screen. Yeah. So, Kriti, you want to try?
Anyone who has not spoken or who does not have much experience, because I think this is a particularly good field for showing what hematocones can be, and how not to confuse them with blasts. This field, this slide especially. Anyone?
Sir, I'm Kriti, sir.
Yes.
So mostly, sir, in case of hematocones and in case of this particular slide where lymphocytes are often confused with them. So the most important factor could be the NC ratio, sir.
Sorry?
Sir, the nuclear cytoplasmic ratio, sir. Sir, in case of lymphocytes, when they're usually seen in a bone marrow aspirate smear, sir. So the cytoplasm cannot really be distinguished from the nucleus most of the time, sir, at least from what I've seen in our institute, sir. Whereas, sir, hematocones usually have a fair distinct rim of cytoplasm that can be visualized, sir, on a bone marrow aspirate smear.
No, but there was one very important feature in this slide which Dr. Sandeep mentioned. I don't know if you noticed. He started with the lowest cell, the one next to the neutrophil. Can you see that?
So yes, sir.
Yeah, so
right corner,
that or maybe the one below a neutrophil next to that. So if you take the bearings from that and if you go and see the other cells, they start increasing in size. And there is a continuum in the morphology from one cell to the other. So there's a whole range. And so as if one cell was transitioning into another. So that is, and so that the largest cell, otherwise you think of a blast. So if you see the continuum, then you will not go wrong. And you people have been introduced to the term hematocone, but many years earlier, we had a case. There was a 10-month-old child, and he had about 70-75% of these cells, and there was an outside diagnosis of ALL. So when we saw it, it was pretty apparent that they were not blasts. So I looked up, and Sandeep would know that Nathan Oski.
Yeah.
Nathan Oski's pediatric hematology book. At the very end, they have got a level of normal values at birth, at 1 day old, at 7 days old, 1 month old, 2 months old, like that. And so I looked that up, and at the age of 10 months, the figure was about 55% plus minus 15% of what they called as lymphocytes and transitional cells. They did not use the word hematogones. So this, and so I described the marrow as showing 75% lymphocytes and transitional cells compatible with the age of the patient. Advice close medical follow-up. So after 2 months, the child was, he was not doing any treatment and he celebrated his birthday. There was nothing wrong with the child. So what I'm trying to say is that by noticing this feature of transitioning without any major great change in the chromatin or cytoplasm, there is some change, of course, but not very much. So if you notice that, that is a good way of getting started with hematogones on morphology. And so that you learn it well, because everywhere, all the places where you don't do morphology, they don't have flow also. So there's no point saying that you can't recognize this, so you have to have flow and things like that. I don't agree with that. So lymphocytes and transitional cells, that is, so that describes the whole scene so beautifully. And mind you, there was no photograph, there was no description given, only these two terms were given. So this is one way of learning. So those who missed this point made by Dr. Sandeep should please note.
I agree with you, sir. Sandeep, want to say something?
No, I completely agree. And I think it's like, especially in patients who are less than 1 year old, you really have to be mindful, because what happens for us is the patients have ITP and they need to get a bone marrow before they can be started on steroids. And you end up with a field that looks like this. And you just have to not, there's so many mature neutrophils here, there's so many lymphocytes here, this cannot be a malignant marrow. So in this particular field, you can see the progression, like this is the least mature cell, then it's here, and eventually you get from here to there to there. So to me, this is what I look at when I'm trying to morphologically decide what these are.
I think what Dr. Rajiv and Sandeep mentioned is the word is context. So in medicine, everything.
This happens in children, and you have to know one thing, that if you miss leukemia and diagnose it 5 days later, it doesn't matter. But if you diagnose a leukemia where there is no leukemia, that is a disaster for the patient, for the family, everyone. So be very careful before you call anything as ALL, especially in children, because you may be going wrong.
Yes, sir. Perfect. I totally agree, sir. So basically, what sir says is context. So you have to know the age, and even these like hematogones look like the blast. Similarly, the good myeloblasts can look like the bad myeloblasts. So that when you see the blast, it doesn't mean they are cancer cells. They can be benign cells. I think I seen a Bhushan raising his hand. Dr. Bhushan. I can't see him. Where is Bhushan now? You want to say something more, sir? Yeah, Bhushan is here. Hi, Bhushan.
Good evening, sir. I just wanted to add.
Yeah, Bhushan, go ahead. You're again muted. Bhushan, unmute yourself.
Yeah, thank you. Good evening, sir. It was a lovely presentation. I just wanted to add to what Dr. Sandeep and Dr. Rajiv very beautifully pointed out on that slide of hematogones, that we have to look at the overall picture. So in addition to what we saw, along with the translational lymphocytes, the background myeloid cells are also showing maturation. So in case of a leukemic picture, we won't be seeing this kind of maturation in the other cell series also. So these are also kind of indirect hints which we can draw conclusions, especially in a scenario when we are seeing one odd cell which looks like a blast.
Yeah. Very true, very true. And even you look at the CBC, the hematogones like blast, they don't come in on the pelvis smear. So if you have a doubt of acute leukemia versus hematogones, just look at the pelvis smear of the child. You'll not see these cells.
Yeah.
Yes. Thank you, sir.
And there are several questions in the chat, and I think I can address them. Somebody wanted to know what is the equipment that I use for the slides. It's just one of the Leica digital scanning microscopes that scans the entire slide at 40x, and then you can put it in your path presenter presentation just like you would a virtual slide. Somebody's asking about what are the reactive lymphocytes in the peripheral blood. Those are usually cells that you see, at least most frequently, the ones that I've seen are related to infections like EBV infection and other viral infections. We refer to them as immunoblasts. They have, almost vesicular chromatin and very prominent nuclei. And again, you see a spectrum. You see some cells that are large with very prominent nuclei. You see other cells that have more blue cytoplasm and the nucleus is clumpy. And so my preferred term for those is reactive lymphocytes, because I don't want to cause confusion. Anytime you say something with blast, even if it's an immunoblast, it does cause some confusion. So I just say reactive lymphocytes. What is the age group under considering hematogones can be seen? It's, you can see it, particularly in young patients, like Dr. Rajiv Kumar pointed out. Up until the age of 1 year, they're very common, but we see them in patients who have received, people get cord stem cell transplants now, so post-transplant patients who are recovering from chemotherapy that have more sort of pediatric-like hematopoiesis in their bone marrow. So you can see them at any age group, but it makes the interpretation particularly challenging in young patients, like Dr. Rajiv Kumar was saying. So 6-month-old babies, 8-month-old babies, they're very, very abundant and can make up for at least, up to 70% of the cells.
Sandeep sir,
Yes.
there are 2 more questions in the chat box. Are there specific features to differentiate dysplastic marrow due to MDS from nutritional deficiencies of vitamin B12 or folate?
No, you need to have those laboratory tests and a good history for the patient, because the mimics for MDS are, very ominous, and the morphology can be very, very scary. But fortunately, for most patients, if they're being seen by a good physician, they would have evaluated for B12 folic acid before they get to a bone marrow. But just on morphology alone, it's difficult sometimes. Sometimes you can see, like it was being mentioned earlier, there's preserved megakaryopoiesis, there's preserved granulopoiesis. The peripheral counts are reasonably okay. You just have macrocytic anemia with a lot of megaloblastoid cells in the bone marrow. You're more likely to think about B12 deficiency, but in some cases that distinction can be challenging, and you do need to keep that in mind. One of the problems we see here is zinc toxicity. So the people who use dentures, the adhesives have zinc in them, and then they develop copper deficiency and very abnormal erythropoiesis in the bone marrow. And these are like 70, 80-year-old patients who have high likelihood of having MDS as well. So again, we rely very heavily on good clinical history. And like Dr. Rajiv Kumar said, if you come back to a patient and make a diagnosis of MDS 10 days later, 15 days later, after you've gathered all the information, it's okay. Rather than make a diagnosis of MDS, expose that patient to cytotoxic therapy, and then realize, oh, the zinc level is too high or the copper level is too high. So we really, unless we have good genetic evidence that this is a clonal process, we won't make a diagnosis of MDS till we are fully convinced and we have excluded other reactive conditions.
Okay, sir. The next question was, is cytoplasmic blebbing a dysplastic feature?
Cytoplasmic blebbing? Not necessarily, no. Do you have a specific context that you're thinking about? Cytoplasmic blebbing is something you see in some very specific entities. For example, megakaryoblast will have cytoplasmic blebbing. Some lymphoid malignancies of mature cells will have cytoplasmic blebbing. But otherwise, a lot of times you'll just see it as an artifact because of the way the slide was made or the preparation. And so you should look at like at least 100 or 200 cells of that lineage before you attribute any significance to the cytoplasmic blebbing.
Okay, sir. The next was, is emperipolysis a diagnostic feature in certain infections?
Like megakaryocyte emperipolysis in the bone marrow, to the best of my knowledge, no. But I don't know if Dr. Gujral or Dr. Rajiv Kumar have something to add to that.
I agree with you, Sandeep. No, nothing, no significance.
And if you're thinking about emperipolysis by histiocytes in the lymph node, that's something you see in Rosette Dorfman, but in the bone marrows, no.
It's normal feature to see in the megakaryocyte, especially in the
Yeah.
groin. You can see
Yeah.
regularly.
Yeah, so then the next question is, what is your advice for measurement of percentage of ring sideroblasts?
Oh, so I don't think I have an advice, to be honest, because depending on what other data you have, are you asking me what is a ring sideroblast? If that's the question, then the definition is you have 5 or more rings going a third of the way around the periphery of the nucleus, and you really have to be mindful that they are around the nucleus, because patients who have chronic inflammation and anemia of chronic disease can have a lot of iron in their cells, and it can look like it's a ring sideroblast, but you really have to see the location of the granules and how many of them are there and how they're placed around the nucleus. If you're thinking about enumerating them to get to a diagnosis of myelodysplastic syndrome with ring sideroblasts, that number is 15%, and I think you count, I don't know, 200, 300 red cell precursors, and they can be very variably distributed, and so you might have to scan multiple areas of the slides to get to that count. And again, I don't know if Dr. Gujral has something to add to that, but
No, Sandeep, I just want to add one or two more things which maybe you added, but maybe I missed out. One was all students, in what I learned from Dr. Rajiv, when you're doing differentials in the bone marrow, when you do the first 100 cell count, there are always cells which you do not know to put them in which category. Monocytes, which, after 40 cells count, you realize they're not monocytes, they're myelocytes. So it's a good idea that you count 100 cells, ignore the count, make up your mind which cells are going to be put in which category, and then count another 200 cells and divide by 2. There'll be a better differential. Many of us just count first 100 cells and give differentials, and there are good chances we'll go wrong in the first 100 cells. So it's a good idea to get used to the slide and cells. Like I said, everything is in context, so sometimes we realize later that these cells I was counting in the wrong category. Second, I would just request you, Sandeep, to tell students once again how do you do differential, because I thought it's more a normal class. We went into the leukemias more. I would request you to tell them about 3 lineages once again, and also do you count erythroid cells when you count 100 cells, or you don't count them? Can you briefly tell them again?
in the bone marrow, we count. So if I feel that it's worth doing a differential, I count 500 cells. And anytime I get stuck at a cell, I do move around and find a cell that I think it is and convince myself, are they similar, are they separate, before I start classifying it. And actually, even before we start counting, we really scan the slide for 4 or 5 minutes for distribution to make sure that there's not some aggregate sitting in one part of the smear that you don't see in other parts. So, at 10x or 20x, even you scan the slide for 2 or 3 minutes before you even start counting it. Then when you start counting it, you go to an area that's as close to the spicule as possible, but where the cells are separated enough that you can see individual morphologic detail. And then you count 500 cells. If you have a myeloma marrow, for example, or if you have a CLL marrow, if you have a staging marrow for lymphoma, and you're short of time, don't count the differential. But if you are going to count the differential, particularly in cases with myeloid malignancies, count 500 cells. I count the erythroid cells as part of the bone marrow differential. They're part of my 500 cell count. And that's how you calculate your myeloid to erythroid ratio. So for me, it's a calculated number. If I'm going to put it in a report, it's going to be the ratio of the myeloid cells to the erythroid cells counted on a 500 cell count differential. And megakaryocytes is the only cell that's not part of the 500 count differential because the number of megakaryocytes is not necessarily proportionate to the cells that are in the peripheral blood. And a single megakaryocyte can give rise to thousands and thousands of platelets. They're also unevenly distributed. They're mostly present in the spicules. So the megakaryocyte count is meaningless and it's not included in the differential, but all other cell types are.
Yeah, please.
I want to ask the students why 500 cells should be counted in the bone marrow. Why? Give me your reason. One is, of course, whatever Dr. Sandeep has said, all that is fine. But your reason as a reason. Give me your reason.
Zahid, are you there?
Anyone, Amita?
Preeti is there.
Yes, sir.
Amita, why would you like to spend a lot of time counting 500 cells? Since you're doing MD, isn't it?
Sir, because there can be many cells which we can skip if we see in less numbers. Like if we do not count at 500, we may skip some of the cells. Like their frequency may vary.
Okay. Well, what else? Anyone? Any of the other students who are participating? There's Diksha.
Yes, so same reason. More number of cells, more area we scan, more number of different types.
No, but I personally think, it really helps. The single most important reason for counting 500 cells, especially when you're in the learning phase, is that you are forced to look at each and every cell and try to figure out whether it is cell A, B, whatever, whether it resembles this cell or that cell, whatever. Then you're forced to look at every cell. Looking at every cell is the single most important thing for learning. And looking means looking even at normal neutrophils. It's not about identifying. Of course, you can identify neutrophils, but if you look at them, you'll learn a lot. So you have a 500 cell count only for your own learning, no other reason.
I completely agree. This is what I tell my resident as well. Like, it forces you to commit to a cell. It forces you to pay attention to what the features are that are making you attribute a given lineage to that cell. It is the only way you will learn how to identify cells, is committing to 500 cells on at least 1 bone marrow a day while you're on your rotation.
So I hope after this you will start you go back and start counting looking at 500 cells basically. If there are many marrow, then not all marrow, but what about any reactive marrow and normal marrow, that is the place where you should really count, look at all the cells. And then any departure from normal, which may be leukemia, which may not be leukemia.
So one more small point about hematogones, because there are some hematologists here. There are many drugs which can cause increase in hematogones. So hematogones you don't see only in infants. Even in young adults, you can see hematogones. So you have to be careful. And now these days, many physicians are giving growth factors. Growth factors for many reasons. So you might get to see certain blast-like cells in peripheral blood. So the good history.
But that's not hematogon. Yeah,
Myeloblasts. I said growth factors, myeloblasts can increase in the peripheral blood. So it's a good idea to take a history, adequate history. Things do not fit into acute leukemia. So like whether they are hematogones, whether they are myeloblasts, I think it's important to have adequate history. Yeah.
Another condition where you can have a blast in the peripheral sphere and mistakenly called acute leukemia is a recovering agranulocytosis. You should try to, at least those who are practicing CR or marrow should remember.
Kaveri, do we have any more questions for Sandeep, or he has to leave?
Yes, sir. So one more question. Is there any specific criteria to distinguish atypical megakaryocytes in renal disease, like more than 10% with MDS?
Wait, renal disease. That's a question I don't know the answer to that. I don't know if there's anything specific about megakaryocytes and renal disease. But in general, yes, it's you. If you're going to call something as having megakaryocytic dysplasia, 10% of your megakaryocytes have to be dysplastic, as defined by the criteria that I have in one of more slides. And there is another number that you need to cross the threshold for. You have to examine 30 megakaryocytes, and 3 out of 30 have to be abnormal. You can't make an assessment on less than that. And sometimes you don't have enough megakaryocytes, and it becomes challenging. But don't overcall dysplasia, especially in megakaryocytes, and even more on refined biopsies than an aspirate, where things can get cut in a plane where it looks like the lobes are separated or they're not enough lobes. So be very careful in calling something dysplasia. I think there's another question about the difference between micromegakaryocytes and dwarf megakaryocytes with respect to relevance in myeloproliferative neoplasm. I think dwarf megakaryocyte is a term that has been historically used in CML. And if you think about the clinical correlate there, CML patients usually don't have thrombocytopenia. They have either normal platelet counts, sometimes higher platelet counts. So I think of dwarf megakaryocytes as just as a morphologic abnormality, but they are productive megakaryocytes. They're making platelets, as opposed to micromegakaryocytes, which can be of comparable size, but are also not productive and not making platelets. So it's just a difference in the context more than the actual morphology. Yeah.
And the next question was, sir, what about lymphocytes and plasma cells? Are they not the part of counting in aspirate?
They are part of counting in the aspirate. I mean, for me, they are. I count lymphocytes and plasma cells because if you lymphocytes is an important count because there can be a lot of lymphocytes and it can skew other things. So you need to be aware of how many lymphocytes are there. Plasma cells, particularly if you're dealing with multiple myeloma, there's a cutoff there, 10% that makes the distinction between MGUS versus smoldering myeloma in the absence of clinical symptoms, and then 60% plasma cells that will get you to a diagnosis of multiple myeloma, even in the absence of CRAP criteria. They are part of the count. They're not part of the calculation of the ME ratio. I exclude them out, and I just use the myeloid cells and the erythroid cells to calculate my ME ratio.
Yes, and one second, one small point. ME ratio is extremely important, as Sandeep says. One more point, like in peripheral smear, we look at 3 cells: red cells, white cells, and the platelets. Similarly, in the bone marrow, you have erythroids, myeloids, which include lymphoids, and megakaryocytes, and there are other cells, obviously. Yeah, Kaveri.
The next question is, sir, can we comment on PBF regarding MDS? What are the things we should look for so that we can advise bone marrow aspiration?
Yeah, so there's obviously the morphology. Macrocytic anemia here is the most common presentation, macrocytic anemia and thrombocytopenia for MDS. So you will have red cell macrocytosis, which is very non-specific and can be seen with 100 different things. So if you see that, you have to advise your clinicians to exclude a whole bunch of things, including B12 folic acid deficiency, liver disease, thyroid disease, etc. Morphology, if you start seeing pseudopelvic USL, if you start seeing cytoplasmic hypergranularity in the neutrophils, you start seeing a lot of nuclear excrescences and cytopenias. That's the starting point for workup of myelodysplastic syndrome. But before you get to the bone marrow, you have to have excluded things like, is the patient on any medication? Is the patient has had any infections that can cause transient bone marrow suppression and some morphologic changes? Is the patient changing their diet recently? Have they started eating something that they weren't eating? Have they put on new dentures or something like that? So there should be a fairly comprehensive history that should allow you to put that morphologic change in the peripheral blood in some context. And if you cannot find a context for it, that's the time when you would advise a bone marrow.
Sandeep, I have a question for you. How important is it to understand clinical hematology for a pathologist?
Just as important as it is to understand the morphology of the cells in the bone marrow. I mean, it's hand in hand, and that's why I find this concept of a combined DM program where you have hematology exposure as well as pathology exposure very interesting, and I think very productive and meaningful. I think you really do need to know a lot of clinical hematology, at least enough to be able to have a conversation with your clinicians, if nothing else.
Sir, one last question. Sir, how do we differentiate ICUS and CCUS with MDS?
I think there is a next level. We'll have this question in the next talk. Leave it for the normal morphology now.
There are no more questions in the chat box.
Yeah, we don't ask this question.
I have a question.
So yeah, please.
Sandeep, you said that in the last part of the bone marrow aspirate, you put in a mesh bag for future use. So typically, how many cells will you get in that procedure? That is number one. And number two, will you put them in DMSO or trizol, or just simply put them at -80 or liquid nitrogen?
Oh, so just a clarification there. So if we have cells left over from the flow cytometry lab, those will be frozen in fetal capsular and DMSO, and they'll go into -80. What I was talking about is the clot particle, which is, when they do our procedures here, they take the aspirate out in a syringe, they squirt it out on a petri dish, and they will use those spicules to make the slides. Whatever's left that hasn't been used to make the slide actually goes into a mesh bag. It gets fixed in formalin, it gets paraffin embedded, and gets fixed like tissue. So there's 2 different procedures that we have for that.
So one last question to you, Sandeep, from my side. So when you do bone marrows, you make aspirates in all cases, or you have now some cases where you do only aspirates, you don't do refine, and you make imprints in all cases? Just briefly, imprints, biopsies, and aspirates, do you do in all cases, or there are cases where you do only imprints or only aspirates, no biopsies?
So at our institution, historically, we have done aspirates and core in all cases. There are institutions where, particularly children's hospitals, where they don't do core biopsies on all patients because diagnosis of their acute leukemias is all morphology and flow and genetics based, so they don't do core biopsies. And particularly in the pediatric age group, post-therapy Marrows, they never do core biopsies. They only do aspirates because they rely very heavily on flow cytometry measurement of residual disease. At our institution, unless there's a problem with the procedure, if they can't get to a core, they don't do a core. Or if they're doing a sterile biopsy because of various reasons, they won't give us a core. But 90% of our cases will have cores.
Sandeep, I just saw one last question from one of the audience, and I think she asked, can IHC help to differentiate, to diagnose hematogones? How? IHCs.
It's an interesting question. So there are, I don't know if you guys know Dr. Kathy Fukar. She is a very good bone marrow pathologist, and she's written several textbooks on that. What she says is you will never see more than 3 hematogones in a cluster. So if you're doing your CD34 and TDT, you should not see, if you see more than 3 cells in a cluster, you're likely dealing with a malignant population. If you have cells individually spread out throughout the biopsy, you're likely dealing with a regenerative process. That has been called into question, especially with more sensitive flow cytometry techniques. Like people have said you can see more than 3 hematogones in a cluster on IHC, but there isn't a specific marker. So there isn't some CD marker that you can throw on your slide and say, oh, this is a hematogone and this is an abnormal cell. Same is true for flow cytometry. You're looking for patterns of maturation. There isn't a single antibody that will tell you that this is a hematogone or a B lymphoblast. So that comes from looking at multiple parameters and getting to that assessment.
We'll have to stop here, Sandeep. There are questions coming up. There are still 145.
I do have to get to work. It's 10
That's what we have to stop here.
for me, so I have to stop.